Greetings, my name is Lindsay Ma, and I'm a rising internal medicine intern. Today we'll be covering diabetic ketoacidosis and hyperglycemic hyperosmolar state, known as DKA and HHS for short. Since this is a big topic, we'll just focus on diagnostics today and save management for another video. This target audience for this talk is clerkship level medical students, so let's see what we can learn today. As you may know, mortality from DKA is luckily pretty low, at around 5%, whereas the mortality with HHS is more moderate, at 20%. However, the complications from untreated DKA or HHS can be really severe and include hypokalemia, which can lead to abnormal heart rhythms, and cerebral edema, pulmonary edema, kidney injury, and even rhabdomyolysis. As clinicians, we can help patients avoid these complications by diagnosing and treating DKA and HHS as soon as possible. Unfortunately, DKA and HHS can present really similarly with polydipsia and polyuria, for example. So it's important to be able to distinguish between these early because the treatment ultimately has a slightly different focus. While in DKA, we focus on insulin, HHS, we focus on fluids. So let's spend a little time today figuring out how to distinguish between DKA and HHS. Let's say that you have a patient with polyuria, polydipsia, and weight loss. From this alone, you won't be able to tell the difference between if this patient has DKA or HHS. So what else would you want to know about them? Perhaps you would want to know their serum glucose, pH of their blood, their beta hydroxybutyrate level, urine ketones. So these are some important items that can help us distinguish between DKA and HHS. When you think about DKA, what degree of hyperglycemia might you expect? Well, in DKA, we would expect something above 200. However, it won't be as high as what we see in HHS, which could be greater than or equal to 600. In terms of pH, we would expect an acidosis in DKA, hence the A in DKA, whereas no acidosis in HHS. So those can vary in severity, where mild would be 7.25 to 7.3, moderate 7-ish to 7.25, and then severe having a pH of less than 7. On the other hand, HHS would have a pH in a normal-ish range. Beta hydroxybutyrate is a ketone that we are able to measure in the blood. It should be normal in HHS with a level less than 3 and should be very abnormal, greater than 6 in severe cases of DKA, whereas it may be in an equivocal 3 to 6 range for mild and moderate DKA. Furthermore, we can look at ketones in the urine. This can be really helpful because ketones are frankly positive in the urine of a patient with DKA, whereas they may be small to normal in patients with HHS. One more item I wanted to discuss was time course. Patients with DKA tend to develop symptoms such as polydipsia, polyuria on the order of a day, whereas HHS is a more indolent, smoldering picture where this could develop over the course of a week or so. Now, to tie some logic back into the table that we've made, let's think through the pathophysiology of DKA. Why do we see ketoacidosis in DKA? Well, that would be because the whole body insulin is actually low. And insulin is responsible for regulating processes like lipolysis, the breakdown of fats. So when insulin is low, it is unable to suppress lipolysis, and we have increased lipolysis. The lipolysis is key because when you break down fats, you inevitably produce ketones, in your attempt to increase the amount of glucose. At the same time, there is also glycogenolysis and gluconeogenesis, but at much lower rates than the lipolysis. In contrast, what is going on in HHS? Why is the glucose so high? Well, in HHS, instead of there being an actual amount of decreased insulin, we have a perceived low insulin because the body is insulin resistant. And despite there being insulin around, the body's not seeing it and not recognizing it. So, because the body thinks the insulin is low, we have increased glycogenolysis, breakdown of glycogen, as well as gluconeogenesis. And this ultimately leads to the elevated glucose that we see here, but without ketones and also without an increase in the beta hydroxybutyrate. So I hope that makes a bit of sense as to why we see the ketones, which are acids in this case, that are unique to DKA but are not present in HHS, and also why the glucose levels are so high in HHS and only moderately high in DKA. So let's move on to the rest of the assessment. When your patient comes in, they have this polydipsia, they have this polyuria, and all these symptoms. You'll initially want to stabilize them, always our first step. We won't go in depth into the ABC since you get training on this elsewhere, but some things you might be looking for are compromised airway if they happen to be obtunded and requiring intubation. And same with hypotension due to fluid losses. They might require some extra support. You might notice that their pulse is tachycardic, compensating for low blood volume. And so you'd want to help stabilize the patient from the perspective of ABCs. You'll then want to ask a few questions and collect a history. Some important things to ask about would be that time course, as well as about precipitating factors, namely causes for infection. That's because when we think about precipitating factors, infection is a major trigger for DKA and HHS. In fact, 1/3 of DKA cases have infection as an underlying cause. And half of the HHS cases also have infection as an underlying cause. Other big contributors are new diabetes diagnoses. Their insulin levels could become very low because they have low endogenous production and ultimately result in a DKA episode. As for the HHS category, about 1/3 of patients have inadequate insulin use, which results in low perceived insulin by the body and the process tumbling into an episode of HHS. Lastly, there are some other smaller contributors to DKA as precipitating factors. For DKA, those are inadequate insulin, as well as iatrogenic causes, whether that be from medicines or procedures. And then for the HHS group, some other contributors include endocrine diseases and iatrogenic causes as well. On our exam, what are some areas that we might want to focus on? Well, I like to start in a systematic manner, first looking at vital signs. As we mentioned before, the patient might be hypotensive. We'd want to be able to treat that, and so that's an important vital sign to look for. Generally, you can assess their odor in particular. Patients with DKA can have an odor due to the acetone that they're accumulating, whereas patients with HHS do not have this signature smell. A neuro exam is also important to assess for changes in mentation. If you can identify that this patient has altered mental status as well as elevated serum osms that are effective in their blood, then you can attribute their mental status changes to this disease process as opposed to something else. A volume assessment is important and will likely reveal a dry picture where their jugular venous pressures are low and they might have dry mucosas. And on your pulmonary exam, you might notice that they're taking these really big, deep breaths, which we also call hyperoosmoloar respirations. And that's to help blow off CO2 in an attempt to reverse the acidosis in the case of DKA. We won't really see this in the case of HHS. And lastly, an abdominal exam. Patients with DKA can develop abdominal pain. The mechanism isn't quite clear, but the suspicion is that acidosis and some of the other electrolyte abnormalities can cause ileus and result in intestinal spasms that result in abdominal pain. While in HHS, we don't have this acidosis, and in recent studies, abdominal pain is very unlikely to occur in patients with HHS. After you finish your exam, you probably want to order some tests. There are 7 labs that are must-gets, and then there are some that we can consider getting. The ones that we should definitely get include serum glucose, a BMP, and the BMP will specifically tell us about what? I'm most concerned about electrolyte abnormalities. Look at the potassium. They may be hypokalemic, which puts them at risk for arrhythmias. And we also want to take a look at their kidney function, which might give us a prerenal picture. We will also use the rest of the electrolytes in order to calculate an osmolar gap. A CBC is important because if there is a very frank leukocytosis, then that could increase our suspicion for infection. A urinalysis is also important to get with urine ketones for the reasons that we talked about before in order to assess for the presence of ketones in the urine. Also, a urinalysis, if it contains lots of bacteria and white blood cells, could point you towards a UTI as the precipitating factor that led to their DKA or HHS. We'll also want to get an ABG or VBG to help us assess the pH of the blood. Again, if the patient's blood is acidic with a pH less than 7.3, this puts us at a higher suspicion for DKA. And we would want to get a serum beta hydroxybutyrate. The serum beta hydroxybutyrate will tell us about the amount of ketones in the blood and make us more suspicious for DKA. Lastly, you could consider getting lipase and amylase to assess for pancreatitis. And you could consider getting various cultures such as blood cultures, sputum cultures, and urine cultures, depending on your level of suspicion for various infections of the body. On that note, you could also consider getting a chest x-ray if you think there might be a pneumonia as a predisposing cause, but you'll definitely want to get an EKG, and that's again to assess for the health of the heart. In the event that there is hypokalemia, we are certainly concerned that there might be EKG changes. All right, so let's summarize. For patients who come in with polydipsia, polyuria, and then you identify that they have hyperglycemia, you might be worried about DKA or HHS. But based off of those things alone, you can't know for certain which diagnosis the patient has, and therefore you won't know exactly how to manage them. By getting the labs that we've talked about, you'll be able to distinguish whether your patient has DKA versus HHS. Some of the key points here is that for patients with DKA, we notice acidosis secondary to ketones being elevated in the blood and the urine, and the time course is short. Whereas in HHS, there's a predominance of hyperglycemia without acidosis and without ketosis. Nevertheless, infection is a very common precipitating factor, and so you should evaluate for these things on your history and with labs as indicated. Your time is precious, so thanks again for joining me for this talk, and until next time.